Sarra Nazem, and I'm a clinical research psychologist at the Rocky Mountain MIREC, and I'll be your host for today's podcast. We're very excited to offer our next episode in our Suicide Postvention podcast series. Today, we'll be concentrating on how to best incorporate suicide postvention practices within private practice and mental health centers. To help us learn more about this area, we're joined by Dr. Larry Berkowitz and Ms. Eliza Jacob Dolan. Thanks so much for joining us today, Larry and Eliza. Let's begin by having you both provide a brief introduction of yourselves. And Larry, we'll have you go first.
Hi, Sarah. Thanks for having us. Great to be here today. I'm Larry Berkowitz. I am a psychologist here in Massachusetts and have worked in both community mental health centers. I was a director of a community mental health center for the organization I currently work for, and for the last 12 years, I've been the co-founder and director of Riverside Trauma Center here in Massachusetts. The Trauma Center, our work is a little different than a lot of other places that we've heard that are call themselves a trauma center. We primarily are working in communities throughout our state and consulting throughout the country with programs, schools, organizations, communities that have had some kind of highly stressful, potentially traumatic event. And part of our funding comes from the state here in Massachusetts, Department of Public Health Suicide Prevention Program, and Department of Mental Health here in Massachusetts. And in that context, we're doing a lot of suicide postvention work. So we are working with schools, communities, mental health organizations, residential programs, outpatient, and we do a fair amount of consulting to private practices and other kinds of programs like that have sadly lost someone to suicide. I also come to this work as a suicide loss survivor, having lost a sibling and several friends to suicide, and that has certainly informed my work. And having had that experience, I think, frankly, like many of us in the field, has sadly enriched what we do, but I think brings a lot of good lived experience to the work.
Great. So happy to have you, Larry. Eliza, would you like to introduce yourself next?
Yes. Hi. I'm Eliza Jacob Dolan, and I have been a outreach clinician in community-based mental health for the last 30 years. I'm right now working with adolescents in high schools and in their homes and in the community. I am also a responder for the trauma center that Larry was talking about. As an on-call participant, I will respond to different needs in the community and work with schools, different settings, and so forth.
Well, so glad to have the two of you together. I just want to get us started. I know our listeners that maybe have checked out previous episodes have definitely heard other experts talk about the rationale and the importance of incorporating suicide postvention practices into various settings. But I just wanted to start there today before we go too far. And Larry, would you mind kind of just helping our listeners understand the importance of why we should be considering suicide postvention and why that's something a place like a community mental health center or a private practice should be considering?
Let me just clarify that, Sarah. When you say should be considering, are you saying that considering having a plan in place beforehand, or considering as a routine and regular practice should there be a loss?
I'd say both. So definitely we love to encourage people to think about having a plan, but sort of why is it important to have a plan in the first place? Gotcha. And then the fact that, it's helpful to have one too, so that you don't have to create it in the moment.
Exactly. Gotcha. And I think you just answered that exactly the way I would have. Sadly, I think many places, individuals and practices and community mental health centers are caught off guard. I mean, we all worry about and, often many of us have experienced the loss of somebody in our work setting. And that's an uncomfortable moment to have to figure out what to do. So certainly you want to have a plan whenever possible, because that will help make the process go as smoothly as possible. I think one of the pitfalls I've seen is that particularly in the organizational setting, people are familiar with doing the sort of psychological autopsy part of it, the case review, and kind of jump into that almost the organizational investigation of what happened and to sort of review the practices. But what that sadly omits then is attending to the emotional and psychological needs of the individual clinician who is working with someone who just lost a client, as well as the other workers who are also impacted by it. So you want to have the plan in advance so that hopefully you know how to respond adequately and respond well if a crisis happens.
No, I was just going to say, in speaking to that, Riverside has done a excellent job of incorporating the steps that Larry talked about. 5 years ago, I had a young man on my caseload die by suicide, and the way that not only my supervisors but my team and the larger agency responded was very supportive with a non-judgmental and a more helpful stance that they had, because of the education that I believe that the trauma center has imparted in the larger agency. The autopsy was done, the record, going through the record and making sure that all my I's were dotted and T's were crossed, but also looking at how did this affect my practice and me personally, along with my team members and the larger group that I work with.
Yeah, I think both of you have really spoken to a lot of things that we know that are true in the field. One is, Larry, as you had mentioned, I think many times folks think about suicide postvention as just this psychological autopsy piece, or sometimes referred to as like a critical case review, structured sort of review of the record, which is definitely important when we think about improving our care as facilities and providers. However, as both of you spoke to, and Eliza beautifully there, that's really not enough when we think about suicide postvention, offering a comprehensive approach. So we want to also be taking care of those that are impacted, affected, and close to the person that has died by suicide as well, whether that be personal and professional, or one or the other.
Yeah, such a good point. And we know the statistics tell us, and these are getting a little old now, I would like to see someone update them, but we know that about 1 in 5 therapists will lose someone to suicide over their career. And we know even more so in training. I think I once read that about 1 in 6 psychology trainees and 1 in 3 psychiatry residents, 1 in 3 will experience a suicide loss in their training. So we know this impacts a lot of people, and we need to be ready to help support them, not only just from being compassionate and trying to help them with that, but frankly, it's a way of taking care of our workforce and making sure we're supporting the people who are being impacted in a potentially traumatic way as part of their jobs.
Absolutely. And, Eliza, I'm not sure if you have anything to speak to on this in particular, but it's also true that these losses can come earlier in one's career, kind of later in one's career. And Eliza, I know you mentioned being in the field for over 30 years and this loss happening in the past 5 years or so. And so I think there's something important to remember, too, that this is something that can happen to a professional across their career.
Absolutely. And the questioning that I went through of, am I, so as a veteran social worker, have I become too distant from the client's needs? Are my assessment skills not adequate? A lot of self-doubting, even though logically and through my supervision, I was hearing a very different supportive message. Larry, one of the tools that I found most supportive and helpful was the coping groups that were part of the postvention, and how that the way that they are constructed gives a voice for everyone in the group. And instead of people feeling fragile around me or around the topic of the client's suicide, that it allowed like a formula for us to follow, and was very productive.
Well, thanks for saying that, Liza, and maybe I could fill you and Sarah and the listeners in a little bit on what Liza was just referring to, this process that we call a coping group. But I think as a little background to sort of set the stage for that, I would just say, and this may be obvious to so many people, and many of us have seen it when we're working with other suicide loss survivors, but actually a couple of thoughts come to mind. One is, you know, some surveys have shown that for a clinician who loses someone they've been working with to suicide, the impact is similar to how other people say they react to a loss of a friend or a sibling. So it's pretty dramatic. It's a profound loss for many of us. And different surveys, Jane Tillman, who's at the Austin Riggs Center in Massachusetts, and others have done some qualitative studies with clinicians who've lost clients to suicide, and they all talk about these themes and these experiences in terms of that sense of the loss, the sadness, but also shame as you're identifying, feelings of guilt, isolation, the worries about litigation, the stigma, the worry about judgments of their peers, and it really becomes almost this disenfranchised grief because they're not getting often the support that other people would if they've lost someone to suicide. So one of the things that we build in, and it's part of our model in doing trauma response work with any kind of potentially traumatic loss, we have this very structured group experience. It's really a guided conversation that we call a coping group that asks a series of questions of people. So in a clinical setting, then we might invite any of the clinicians who have been impacted or who would like to attend, as well as the person who is working directly with the individual who died, to this meeting. We're doing this maybe a week or so, week and a half or so after a loss, where we ask a series of questions, ask people just to share some of their narrative of the experience of the loss, what their reactions were. We do a little bit of psychoeducation about the things we know about both suicide loss and what's particular to clinicians losing someone, but then really ask folks to spend some time focusing on self-care and what are they going to do to take care of themselves in a particularly vulnerable and difficult time. And we've had a lot of really positive feedback from this model.
That's great. I think one of the most powerful elements there, as you described, is what sounds to be a good amount of flexibility. So a process or kind of a guiding framework, but it allows each group to kind of take it as their own based on the particular death or maybe based on what each of the individuals are experiencing, which I think is something so important for the suicide loss survivor experience, knowing that not one kind of story or description will fit everyone, that it's really unique.
Yeah. Yep.
Well, I think, one thing that might be helpful, it sounds like this coping group or this guided conversation is a major element of the postvention practice that you all deliver. I'm curious what other recommendations or components are typical to a postvention practice that you all execute, or perhaps when you're consulting with other groups that you encourage them to execute.
Sure, there are a number of steps that can be followed, and actually, let me now. This might be a good time to mention a couple of resources. One is that the American Association of Suicidology has on their website a lot of great information, but there's a tab they have for suicide loss survivors, and under that is a specific tab that's related to clinicians who are loss survivors, suicide loss survivors. There's a lot of really good information and resources there, bibliographies, all kinds of great things. They have a phenomenal listserv that there are many of us throughout the country who participate in to offer support to one another. But you'll also find on that resource a couple of documents that were created by Jeffrey Sung, who's a psychiatrist at the University of Washington, and he's developed a sample protocols to use for postvention for private practitioners and for clinic responses, for mental health center responses, that really outline a lot of the steps in a very, very helpful way. And they go through things like identifying what are some of the immediate responsibilities. So immediately following a loss, what are some of the things that you need to do just in terms of making contact with people, reporting it to supervisors, being in touch with your malpractice insurer, all those real basic logistic kinds of things. But then also moving into like managing emotional support, like getting peer support, getting supervision, and those kinds of things. There's been some interesting conversation that I've seen, some differences. Some people will advise a clinician who's just lost a client to suicide to be a little careful in who they choose to speak to. And some of that's come from the lawyers who warn us to be careful that if there's a worry or a fear of litigation, that if you're talking to peers in a practice setting, that those conversations are then open to discovery in litigation. Whereas if someone checks in for consultation with their own therapist, those conversations have more privilege to them and are more protected for privacy. So an interesting kind of dilemma, because on the one hand, we do want to encourage people to turn to their peers and get support and not feel disenfranchised from their therapeutic community. I guess some of that decision about who are the best people to seek support from could probably come from a conversation with both a lawyer and a supervisor about who are the best people to turn to for that kind of support. So then you heard us talk a little earlier about both the combination of dealing with the inevitable, like the investigations, the record reviews, all those kinds of things. And I've got to say, over time, we have heard so many people, particularly people who work for agencies that are funded by state governments, a Department of Mental Health is similar. There are all these reviews and the investigations, no matter how careful and benign the investigators try to be, people really end up, just because of the nature of what we're dealing with and the emotional reactions, they're already probably blaming themselves and beating themselves up, which is a natural reaction. So it's a precarious moment, and we want to make sure that people are getting good emotional support during that time as well.
As I listen to you talk, Larry, and the legal implications of it, I just wanted to highlight how, so this suicide was on my caseload, it impacted the whole team in different ways. It impacted everyone. So the loss of being able to share that emotional, or to be able to support each other emotionally that way with people in your own practice or within your own mental health setting, would be a big loss.
Yeah, and that's why I feel reluctant even bringing that issue up, but I feel like it's important for people to at least consider that and to think about it. And that probably depends on the circumstances and the nature of the loss. I'm glad,
Absolutely.
Eliza, though, I'm glad that you mentioned something else too, which is I think one of the early things that needs to happen after there's been a loss is for the clinician and the supervisors to really sort of map out and think about, so who else is going to be impacted by this loss? It's obvious that the clinician who's working with a person, but you need to think out, like you're saying, is there a whole team that was involved and might know this person? Will they feel vulnerable because they also work with people who have a fair amount at risk? What about your front desk person? The person who's the receptionist who greets folks who come in. That person perhaps is, I can think of a practice we consulted to out in the western part of our state recently where, it hadn't even really occurred to anyone, but when we got together and we're having a coping group, the receptionist was talking about how hard it was for her every week at that time that she was accustomed to seeing that person and chatting with that person, had sort of a friendly weekly interaction, and that person wasn't there anymore, and how hard it was for her to deal with that. So yeah, who are the other people? Is this, was this somebody who's in a group? Are you going to have to notify other group members? How do we manage confidentiality around that? There are a number of challenges here that, as you play them out, we have to think through carefully.
Right.
Yeah, I think a couple of things that I just wanted to further highlight that both of you spoke to there is, one, this importance of really using an inclusive approach to thinking about who do we want to support and provide resources to. I think at times we may get a bit too narrow in that thinking, and I believe what you two shared there really show how suicide loss can have impacts in different ways across people that may not sort of come to mind first. And I think especially when we're thinking about a mental health setting, there's so much team practice that happens too, that Eliza, what you spoke to, the importance of being able to share and talk with colleagues to really help go through the process is really instrumental. We know from some of the empirical literature that exists out there, I think a common reaction or response is to kind of pull away and isolate a bit because it feels tremendously overwhelming, as we talked about, both that kind of professional and personal impact. But what we know from some of the literature too is that oftentimes when people isolate and they're not able to receive that support or have those conversations, that can be a real barrier to thinking about resiliency and kind of the post-traumatic growth that can come from something over time. So I'm really glad the two of you highlighted those two aspects, because I think that's something important for listeners to keep in mind as they're designing or potentially developing a postvention practice. So I'm curious, I think we've talked quite a bit now about some of the recommendations of what to do sort of in the immediate aftermath in terms of a death, thinking about the first 24, 48 hours, thinking about the first couple of weeks. Curious to hear what the two of you would recommend, thinking a bit more long-term about how to continue providing resources and support for folks and a more kind of longitudinal look, so not just that first couple of weeks, but thinking about a couple months or even a year later.
Yeah, Sarah, one of the biggest supports I've seen, I mentioned before, you'll hear me sounding like a big cheerleader for the American Association of Suicidology, this task force on clinician survivors that was started by Nina Guten and Vanessa McGann, two psychologists who are members of the AAS, the American Association of Suicidology. They created this listserv, which I'm a member of, and I don't often contribute as much as I wish I would or should, but I always read and watch, and it's just been this wonderful place where people give and receive support, both people who've lost clients and people who've lost friends and family members, because those kinds of losses impact our work as clinicians as well, and I've really seen that be an ongoing support for people. And similarly, at the annual AAS conference, which is in April each year, Vanessa and Nina have moderated a get-together of clinicians who identify as loss survivors, where people are able to sit together and talk about these very issues that we're talking about and support each other and have shared experience, which is really important. We've been able to do that here in Massachusetts several times over the last few years. Massachusetts Department of Public Health runs a really comprehensive and quite good annual 2-day conference on suicide prevention, and we've facilitated a couple of times these support groups, basically for people who identify as professionals who are loss survivors. And I was pleasantly surprised initially. I thought it would be a group of clinicians, but it wasn't just clinicians. People who were coming in who identified as case managers and people who work for state agencies, who, all of us who are interface with and impacted by people who have mental health challenges, and having opportunities to come together and talk, I guess is what I'm saying, is really, really a valuable experience.
Oh, go ahead. I was going to see what has been helpful for you thinking about long term.
Continuing to educate myself, continuing to go to the conferences as a participant and to be taken care of at them, to partake in the group that Larry talked about, as a clinician who has had a loss on their caseload. I think also talking about continuing to have the place within my everyday work to be able to talk about it if I need to. If my caseload, if the acuity gets too high, and it triggers something for me around the loss, then, I can access more supervision as I need to. There's different people that I can access that I know, who can offer me the different pieces that I need. That breaking the isolation has been, and continuing to break the isolation has been important into reaching out to different supervisors or mentors when the acuity of my caseload gets to points that triggers some of the old thoughts for me.
Yeah, I think it's so helpful that you brought that up, and I think probably really validating to those clinicians or providers or perhaps folks working in mental health settings that have maybe experienced something similar, where as much as we would like it to be, it's not just a one-time event or occurrence. And I think you speak really nicely to the fact that this is something that over time we want to keep having the conversations about, checking in with ourselves, checking in with supervisors and trusted colleagues to really make sure that you're taking care of yourself both personally and professionally. So I really like how you would describe there that over time this changes and it evolves, and some days probably are easier than other days, but it's kind of part of that journey too.
Yeah, you say that so well, and I agree with both of you. It's such an important piece to be able to bring that to good supervision, to bring those issues to be able to talk about, and I think for many of us, I've heard many clinicians talk about this period of sort of self-doubt, and they're doubting their choice of their profession, and it really takes some time to move through that. There's this sort of existential crisis that happens, I think, for many clinicians who've lost someone. And as you're emerging from that, I think a lot of people are almost like a hypervigilance towards the suicidality, and then feeling incredibly conservative around the decisions that you make afterward. And we really need good supervision to help with that, and need to be sure that we're bringing those issues up ourselves with colleagues or supervisors.
Yeah, I think it's definitely one thing to keep in mind is that it's both sides, right? It's those of us as individuals, as clinicians and providers, kind of knowing ourselves. And another important piece of the message is having supervisors, managers that also help make those conversations easier by making sure that they're attending to that, creating a safe space to talk about it too. And so I think there is a huge role that supervisors and managers play as well, just being aware of the process and making sure that they're checking in over time, because that really communicates the safety and the fact that this is an ongoing discussion too.
And I was thinking about it too. This might be more the short term than the long term. Your question was about the long term, but as we've been talking, I've been thinking about a couple of contexts that we've been in where we were responding to once or twice. I can remember responding to a psychiatric emergency service program. So it's not individual therapy, but it's folks who are doing those crisis evaluations and then have experienced a suicide loss. And I remember having a conversation with the director of that service saying, it wouldn't surprise me if the entire team here is extremely conservative and that you see your rate of hospitalizations going up in the short term. And indeed that happened, because people were all the other clinicians who were involved became so worried and hypervigilant and didn't trust themselves because of the experience one of their colleagues had. So there was a ripple effect there to how other people practiced.
Absolutely. I think that's so true, Larry, that's definitely part of the normative kind of response or reaction where people may change their style of practicing to either be maybe a bit more defensive in that practice because it's coming from a really, really good place where we don't want that outcome to happen again with someone that we're working with. And we know that, the whole goal of our profession is to really help promote self-efficacy in those that we're working with. And so I think this is another really subtle but important point of how being able to be in a trusted, safe environment where people are having these conversations is so helpful to, one, our own personal experience, but two, actually providing the best care we can for those that we're working with, because ultimately we want to, help them kind of share in that responsibility and be independent in managing their own safety as well. And if we're being a bit too cautious or a bit too defensive, we're not allowing individuals to achieve that type of growth too.
A thought that comes to mind as you ask the question about longer term, and maybe this is a slight tangent to that, but if we think of postvention as good prevention, to paraphrase Edwin Schneidman, who was one of the sort of early founders of the American Association of Suicidology, he talked about postvention, when it's done well, prevents the next generation of suicide deaths. Becomes prevention. I think it's a good opportunity to remind all of us that we have to be doing our best to provide our trainees, our students, our younger clinicians, with good evidence-based training on how to assess and manage suicide risk. The data out there, sadly, tells us that majority of clinicians in their graduate training don't get that. They don't get the training on what is, arguably for most of us, our biggest concern in doing the work, to how to assess and manage, using best practices, suicide risk and to treat it. So I think, we should all be doing this always, and I'm really relieved to hear that some states are finally starting to require it. Continuing education for relicensure around suicide, continuing education around suicide assessment and treatment. So I think as a field, mental health clinicians really need to be doubling down on making sure we're getting adequate training for our folks. It will be another way of not only protecting our clients, but protecting us as a workforce from having to deal with these potential losses.
Yeah, I think that's so true. And the other piece that I think is the goal behind this particular Postvention podcast series is the fact that many professional caregivers actually receive no training or education on suicide postvention as well. So definitely it's true about sort of the suicide prevention side, about assessment and treatment and management. I think there are a few graduate schools that are still offering that compared to how many graduate schools we know that are out there. And this particular piece of a comprehensive suicide prevention program, thinking about suicide postvention, is often a neglected piece too, which is, one of the goals behind having this series is to highlight the need to make sure that we're attending to this piece of the comprehensive program as well.
Yeah, thanks for doing that. Yeah.
Yeah, absolutely. Well, one thing I wanted to ask the two of you is we have the different episodes that are featuring different places where people may be practicing where suicide postvention could come up. But I'm curious, based on the two of your expertise, if there are specific recommendations or things that people should be thinking of if they're working in a community mental health center or a private practice. So things maybe unique to those settings to really have in your mind when developing a postvention process or plan.
I think, as you said earlier, and as we were talking about, having a structured plan is probably important. To have some kind of it's basically a crisis plan and some protocols spelled out in advance, whether that's something that you find online or start to create for yourself, or maybe for people in individual practice. That I know many people in individual practice have peer group supervision, or this might be a good opportunity to develop a plan with peers, either in a shared group practice or others in the community, on how they might support one another if there's a suicide loss, and to have that sort of spelled out in advance so they know how to manage that. And similarly, I would say for those community mental health centers, those places that are part of a larger organization, that they encourage their organizations, whether that falls in the quality management department, or that they build into their plans a way to take care of the emotional and psychological needs of the clinicians who are doing the work.
And that's where I would add, Larry, or highlight what you just said about on the micro level of that, for the individual clinicians, if you're in private practice or in the mental health setting, the community mental health setting, to identify who are your mentors or who are your supervisors who can support that. Where is the dialogue that you have beforehand, so that it's not just at a crisis point when you are trying to access that?
It speaks to just practically how useful it is to have the conversations up front, because it's so hard to assemble something or to figure out and make all those decisions and have clear logistics when you're grieving in the moment as well. I'm curious also, we talked a little bit about components of a postvention process. We've covered kind of short-term as well as long-term considerations, the need to have inclusivity and openness in the conversation. I'm curious if either of you would recommend or thoughts that you have on whether or not it's helpful to have a team that's executing a postvention process? Like, would you recommend that it should just be one person's responsibility, or would an ideal best practice be to have a couple folks that come together to carry the process?
Well, as a director of a center that does that work, I can tell you that we would certainly recommend a team. And actually, we felt very fortunate to be able to do this for people here in Massachusetts and neighboring states. I don't know how many similar kinds of programs are out there, but it'd probably be useful for practitioners and clinics to look and see if there are any places in their communities that do specifically do that kind of work, that have experience in doing suicide postvention, not just crisis management. But yeah, I think it's safe to say most of us are proponents of a team approach to any of this because, as we've been saying, many people are impacted by a loss. So if you have a team, then you have a better chance of having a couple of people they may be exposed to the loss but may not be impacted by it at the same level. And those are the people you want to be able to turn to for supports. We've even heard a number of the practices that we've helped support say that, the practice directors have said to us, I knew all the steps to go through, but it's been really helpful just having a chance to review this with someone external to the practice. So I think that often is helpful to have someone who's a step or two removed.
And I think as we kind of wrap up and come to a close here for this particular episode, I'm curious what advice or recommendations you would have for listeners in terms of how to get something started, where to start. You've mentioned, of course, the American Association of Suicidology, but let's say we have listeners that want to bring a postvention practice to their work group. What would you recommend on kind of where to start and how to navigate that process?
Well, I would say doing some of the research. You're right, going to those websites, doing some education, making sure that people do some good readings. And actually, well, you mentioned that you will list some resources. I'd be glad to mention some other resources out there. There are people like John Jordan, who speaks and writes a lot about this, and he has edited a book where with a lot of contributors talking about that experiences of loss and suicide bereavement from organizational perspectives, which is a really good resource. So I think a lot of it is collaborating as groups, either with other practitioners if you're in private practice, or making sure that there's a work like a task force in a clinic setting to start looking at these issues and start outlining what would be the pieces. And you don't have to recreate the wheel, is one of the things I'd say. There are some resources out there to start providing the structure and then filling in what would be specific to a given organization. And as you've said, a lot of the steps would have to be individualized based on the particulars of what's happened. And and there are a number of other pieces too that I think that would come from part of postvention we haven't really spent much time on, is talking about some of the pragmatic logistic pieces, like how do you manage talking to the family of someone who's just lost a family member to suicide, and how do you deal with the pragmatics of the insurance issues and the like. That information's all out there, and some of that can be discovered by talking to legal counsel. But again, you're absolutely right. You want to start doing the planning, start developing some policies and procedures, and make sure there's something that people are aware exist. So one of the problems I think for many of us in organizational settings is we often do some great work developing policies and procedures, and they go into a nice notebook somewhere or in a file on the computer, and then people don't look at them again. So making sure that people review occasionally so that they're aware of what they've created and what's out there to help support them.
Yeah, I think that's true. One of the recommendations is, of course, to always go back to your plan, kind of revise it annually, check in with key stakeholders or folks if a loss does occur, about ways to improve and kind of further strengthen the process or the plan. It's never a sort of once it's written up, it's done, and kind of close it in the drawer. So I think that's a great point.
And probably the most essential piece to any kind of crisis situation, particularly in postvention, is to at some point, several weeks out, maybe after a situation, is to make sure you do some kind of a review, an after-action review, a hot wash it's called in some settings. People have different terms for them, a debriefing, but it's important to review the whole process and to ask, did we learn things that will be helpful to us moving forward about our care and practice with our clients and our patients? And did we take care of the people who work here and need to be taken care of so that they can all grieve well and respond well, and as you pointed out, hopefully move to a point where there's some post-traumatic growth and they can feel like they are able to transform this loss and this grief into something meaningful that carries them forward. That would be something to look back for to see, were you able to achieve that?
Well, as we kind of wrap up here, I always like to check in with folks that we feature on the podcast to see if you have any last pearls of wisdom or last words, or perhaps anything that you had hoped to talk about in the episode but just haven't gotten a chance to speak to yet. Eliza, I'll turn to you first and see if there's anything else that you'd like to share, any kind of parting words for the episode today.
I think a major part of the Postvention work that I learned as a person as well as a clinician is to notice the reactions that I was going through. So notice how I was more sensitive, or how I was hypervigilant, or how I was crying at a moment's notice, or how I was laughing, and not judge that and not be judged for those. And that was very helpful.
I think it's so helpful to just give ourselves that permission. I think it's the permission and the expectation that we set for those that we work with, and sometimes it's hard as professional caregivers to give ourselves that permission. So I think that's such an impactful point that you shared there.
Thanks.
And Larry, how about you? Any kind of final parting words or anything else that you wanted to kind of touch on before we finish up today?
Yeah, I think I mostly want to thank listeners for the work that everyone is doing in this field. As mental health clinicians, we give our hearts and souls to the people we sit with and talk with every day, and we take on an incredible amount. We listen to stories that are often incredibly difficult. We meet with people whose lives are incredibly challenging, and we bear a lot of that. We carry a lot of that. And while it may sound almost formulaic, and we hear this often and say it often to each other, the need to take good care of ourselves is essential. It's Laura Vandernoot-Lipsky in her book on trauma stewardship called this, I believe it was her term, an ethical imperative, that we have to really care for ourselves if we're going to care for others, and we have to take that seriously in doing this work. It's intense work, and hopefully we don't ever have to walk down that path of dealing with a loss, but we may have to, and even if we don't, we're dealing with incredibly intense situations and stories all the time. So I just want to put in another good pitch for making sure we're doing what we need to revitalize ourselves. We often, at our center, quote the saxophonist Charlie Parker, who said, "If you don't live it, it won't come out your horn." We need to truly take care of ourselves and nurture ourselves and each other so that we can continue to nurture the people we work with every day.
Yeah, I think no better way to close this particular episode than what the two of you shared there. I think this work related to suicide postvention is so fitting into that philosophy, and it's also true that just doing these things to care for ourselves so we can care for others is just critical to the work that we do, whether or not a suicide loss does or doesn't happen across our careers, but just being really mindful, and again, that sense of allowing permission to have these conversations, to have these topics. And I want to say thank you to the two of you for just so beautifully describing your experiences in different ways and providing really tangible, concrete steps for those that are listening that are looking to either start a postvention practice or perhaps to kind of revise or refine their own. And thank you both for sharing your own personal experiences as well, as I think that provides, again, that sense of permission and acceptance to really show that emotional side too. So thank you both so much.
You're welcome.
Thanks for doing this series. It's really important. So glad you're doing it.
Absolutely. Thank you.
This podcast is brought to you by Uniting for Suicide Postvention, USPV, in collaboration with the American Association of Suicidology Clinical Survivor Task Force. USPV offers suicide postvention resources designed for family, friends, acquaintances, employees, supervisors, managers, and professional caregivers, including mental and medical health providers. USPV is funded by the Veterans Health Administration Office of Mental Health and Suicide Prevention. Thank you for listening, and be sure to check out our other episodes in this Suicide Postvention series.